Good morning and welcome to the Department of Medicine Grand Rounds hosted by Hamilton Health Sciences today. Today, I'm pleased to have Dr. Madhu Chari as our speaker. Dr. Chari is a respirologist, mainly at St. Joseph Healthcare, but regularly provide consult service at the Hamilton General in Hamilton Health Sciences. He's a clinician educator and assistant professor at the McMaster University, Department of Medicine. He completed his MD and internal medicine training at the University of Toronto and his adult respirology and sleep medicine fellowship at McMaster University. He has a clinical interest in non-invasive ventilation and the management of sleep-disordered breathing. He's currently the clinical lead of the inpatient sleep medicine service at St. Joseph Healthcare. And Dr. Chari has various educational and administrative roles at the university, including serving as an academic coach for adult respirology program, as well as competence committee chair for the sleep medicine AFC program. Dr. Chari will be speaking to us today about update on parapneumonic effusion, something we see regularly. So I'm looking forward to learn from Madhu today what's new in this area. Without further ado, Dr. Chari, please go ahead.
Great. Thanks, Dr. Zahn, for that introduction. So, indeed, today I'll be providing an update on parapneumonic effusions. So after nearly, 12 or 13 years, the British Thoracic Society, or BTS, has published updated guidelines on various pleural diseases, including pleural infection. And with this in combination with how often we encounter pleural disease and pleural effusions, I felt it would be of interest and relevance to many of us as internal medicine specialists and subspecialists. So I don't have any relevant conflicts of interest to disclose. So I'd like to begin with a land acknowledgement. So we at McMaster and the affiliated hospital campuses recognize that the lands on which we provide care are the traditional territories of the Mississauga and the Haudenosaunee peoples. These territories are the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between nations to peaceably share and care for the lands around the Great Lakes. So these are our objectives. We're going to talk about the pathophysiology and epidemiology of parapneumonic effusions, discuss the clinical manifestations and the evaluation of them, provide an overview of the treatment of parapneumonic effusions and focusing on pleural infection specifically, both in terms of pharmacotherapy, intrapleural therapies, chest tube drainage, and so on. And then we'll touch upon when surgical intervention from thoracic surgery should be considered as well. What is out of scope for today's talk would be post-surgery empyemas, tuberculous empyemas, and then an infected pleural space in the context of TPCs or IPCs known as indwelling pleural catheters. So pleural infection is a term that encompasses complex parapneumonic effusions and empyema. And this idea was reliably described more than 2 millennia ago by Hippocrates. And despite advances in diagnostic and therapeutic strategies, pleural infection remains an important problem that continues to be associated with a fair bit of morbidity and mortality worldwide. Parapneumonic effusions, known as the accumulation of an exudate associated with an ipsilateral lung infection, is documented to occur in about half of patients with community-acquired pneumonia. In short, this results from visceral pleural permeability from adjacent lung parenchymal inflammation, leading to accumulation of interstitial fluid in the pleural space. These can be biochemically simple, which is about 90% of the case, or more complex. Pleural infection is seen in about 10% of community-acquired pneumonia-related effusions and include biochemically complicated effusions, or CPPE for short, as well as empyema, which means there's frank pus or detection of organisms on microbiology. The basic principles of treating pleural infections really have not changed since the mid-20th century and really are centered on adequate drainage of the infected pleural fluid, nutritional support, and appropriate antimicrobial therapy. And despite the advances in detection as well as management, one-year mortality has not appreciably improved. It's remained steady about 20 to 30% at 1 year. So in terms of pathophysiology in general, empyema has been historically conceptualized as a spectrum with 3 different phases or stages. The first one is a simple exudate, second is fibrin or purulent, and third is organizing with a pleural peel. In the early exudative stage, there is fluid movement into the pleural space due to increased vascular permeability, in turn accompanied by the production of a number of pro-inflammatory cytokines as listed here, including IL-6, IL-8, TNF-alpha, and so on. This results in further intracellular gaps between pleural mesothelial cells to facilitate fluid entry into the cavity. The fluid at this time is typically more free-flowing, relatively low white blood cell count, low pH, low glucose, and should contain, at least not overtly, any microorganisms. At that stage, antibiotics alone is likely to be adequate. If detected later and if appropriate therapy is not commenced, the effusion will progress to the fibrinopurulent stage, where there's increasing fluid, bacterial invasion across a damaged endothelium, and accelerated immune response, leading to further migration of neutrophils, activation of the coagulation cascade, fibrin deposition that can coat the visceral and parietal pleural surfaces, further dividing the pleural space into these little loculations or pockets. Further, there's neutrophil phagocytosis and release of cell wall components, including proteases, along with bacterial metabolism, overall leading to increased lactic acid, increased CO2 production, and increased glucose metabolism. There's also a rise in LDH from leukocyte death. Collectively, this leads to the biochemical characteristics that we're all familiar with of a fibrinopurulent collection, namely low pH less than 7.2 typically, low glucose, and a high LDH, often in the thousands. Purulent fluid, or an empyema, can develop in the context of bacterial and leukocytic cell death and lysis. The final stage, which is really what we want to avoid, is the organizing stage. So this entails the proliferation of fibroblasts, eventual formation of a solid fibrous pleural peel, and this can potentially encase the lung and lead to a trapped lung that's unable to successfully re-expand. This can not only impair lung function, but create a persistent enlarged pleural space with potential for reinfection. With a combined incidence of over 80,000 cases per year in the UK and the US, pleural infection continues to be a considerable burden to healthcare systems. There have been a number of studies demonstrating that the incidence of pleural infection is generally increasing across North America and Europe, and this figure is lifted from a 2023 review demonstrating that general increase in incidence over time. This trend is particularly notable amongst those over the age of 60, and is that age group which accounts for nearly 2/3 of adult pleural infection hospitalizations in the US. The precise cause of the increasing incidence is not entirely clear, but there's a number of working ideas which I've listed. And while there's an equal gender distribution in children and adolescents, there is a marked male predominance, approximately 2-to-1, for adults-related pleural infections. There are 2 Canadian database studies reporting on the epidemiology and management of empyema. One was led by the UBC thoracic groups, including Christian Finley, who's one of our thoracic surgeons here. The primary objective of this study was to evaluate whether there's an increasing incidence of empyema, as noted in other international studies, and secondarily to determine if it affected any particular age group disproportionately. They used CHI discharge database data to evaluate national empyema trends between 1995 and 2003. Overall, across 11,000 patients, they did confirm the 2-to-1 male to female ratio for those who have empyema, and they found that the median length of stay was about 14 days. Overall, they found that the incidence rate, at least accrued incidence rate, did increase by 30% over that period. But when age adjusted based on standardized populations, it did decrease to about 12%, but nonetheless, an increasing trend. This other study published in Chest in 2022 was published by the Queen's Group, which reviewed that same database, but over a longer period of time through 2015, but focusing primarily on adults. Overall, they found that there was an increasing incidence of parapneumonic effusions and empyema, but fortunately, there was decreased mortality both in the short term and at 1 year. Not surprisingly, after 2010, which is when we started to see a lot of publication of intrapleural enzyme therapy trials and studies in general, there was more non-operative management. And within surgical procedures, there was an increased uptake in minimally invasive surgery, or VATS, after 2004. A recent systematic review looking at data from over 200,000 patients found that prevalence in pre-existing comorbidity in pleural infection is quite high. About 72% of patients with chronic respiratory and cardiovascular conditions having the highest contribution to this. Independent of other risk factors, patients with diabetes were twice as likely to develop pleural infection, and within pleural infection cohorts, the prevalence of diabetes was 5 times higher than the general population. Malnutrition and alcohol misuse and abuse are also important risk factors to recognize as well. Smoking is more prevalent, noted in, on average, 40 to 50% of patients who are admitted with a pleural infection. What's kind of interesting is this potential protective factor of comorbid COPD, and it's thought that this is due to maybe a dampened intrathoracic and pleural, really, inflammatory response from chronic inhaled corticosteroid use. Could be the case. But there's also some consensus and task force opinions wondering whether it also has to do with lung mechanics because of the hyperinflated lungs, maybe increased intrinsic pleural pressures, maybe. Concerningly, multiple databases have reported concurrent lung malignancy, rates of about 10% in patients who are admitted with an empyema. So the classical description of non-resolving pneumonia symptoms such as cough, sputum, fever, chest pain, pleuritic or not, with physical exam findings suggestive of an effusion is certainly the typical or textbook indicator of a pleural infection. However, this is not always the case, right? So we know that certain populations can present more nonspecifically and insidiously, such as the elderly, those with baseline frailty, and for other reasons, undiagnosed chronic aspiration, silent or otherwise, and those ultimately found to have anaerobic infections actually tend to present a bit more atypically. The patient's median duration of symptoms before presentation to ED is about 14 days. Now, overall, one should really suspect the development of a pleural infection if there's a lack of clinical improvement when treating a patient's pneumonia with seemingly appropriate or adequate antimicrobials. And patients should be evaluated further if there's really no improvement in vitals within 4 to 5 days. With regards to microbiology in general, the isolated pathogens do vary between community or hospital/healthcare associated infections. So in terms of community-acquired organisms, this is summarized here in Table 1 from the original 2010 BTS guidelines, which in turn are based on pleural fluid microbiology from one of the larger multicenter RCTs of empyema, the MIST-1 study. And that study found that gram-positive aerobes were the most frequently identified organism, with streptococcal species accounting for about half of cases and 11% resulting from staph infections. About 20% of infections included anaerobic bacteria. And gram-negatives, though, less commonly cultured out. And these are generally seen in patients with comorbidities. Klebsiella pneumoniae in particular has been associated with, more strongly associated with underlying diabetes. The frequency of anaerobic isolates appears to be rising, and in various series, anaerobes are detected in generally about 10 to 24% of samples by culture. And if PCR testing was employed in these studies, it's picked up in up to 75% of patients. In hospital-acquired pneumonia on the bottom half of the table, it's been shown that up to half of patients with positive cultures isolate Staph aureus, the vast majority of which is due to MRSA. Gram-negative organisms, particularly E. coli, Enterobacter, and Pseudomonas, are responsible for the remainder. That same study examined 1-year mortality in these patients and found that this was substantially higher in those with gram-negative infections as well as Staph aureus infections. There was a 2022 study published in Lancet Microbe last year, which looked at next-generation sequencing of ribosomal RNA. They looked at pleural fluid samples from over 200 patients with pleural infection, and they found that almost 80% of infections were actually polymicrobial in nature. Fungal empyema is exceedingly rare, less than 1% of cases, and the vast majority of patients are immunosuppressed or immunocompromised. The underlying organism in this case is typically Candida, followed closely by Aspergillus. It does confer, unfortunately, a high degree of mortality, up to 73% in the short term. In short, viruses are rarely thought to be the primary etiological factor for pleural infections, and to date, there's no real convincing evidence of a COVID-19 related empyema. So X-rays are often the first imaging approach when assessing a pleural effusion, and the typical textbook findings include, blunting of the costophrenic angle, the cardiophrenic angle, loss of your diaphragmatic silhouette, and typically a more gravity-dependent distribution of lung field opacities. In parapneumonic effusions, you would additionally expect to see coexisting pulmonary airspace disease or infiltrates with the pleural base opacity and presumed diffusion. However, based on the complexity and the organization of the fluid, keeping in mind those 3 stages of empyema, it may not exactly be distributed in a nice gravity-dependent manner. In the empyema end of the spectrum, one would expect more of a lenticular or lens-like shape, making a relatively obtuse angle with the pleura, whereas in simpler or non-infective fluid, you would see layering out with a meniscus with concavity towards the lung parenchyma. All that being said, though, the performance characteristics of plain film is rather poor. Thoracic ultrasound is important as a diagnostic tool as well as a mean to improve the safety of pleural procedures. We know that if there's a lack of signal or an anechoic collection, this can be seen in both transidates or exudates, so it's not very specific for either. However, if you see echogenic fluid, this dramatically increases the likelihood of an underlying exudate. Furthermore, if you see homogeneous echogenic fluid, this is most likely due to an underlying empyema or hemorrhage. Septations representing fibrin strands as seen here, or fully enclosed loculations are also quite convincing findings of underlying complex parapneumonic effusion as well. There is no robust prospective study comparing diagnostic modalities like ultrasound, X-ray, etc. But there is some retrospective data to suggest that ultrasound is superior at ruling in pleural infection compared to X-ray and CT. The updated guidelines recommend that thoracentesis should always be done in an image-guided manner, which certainly has been the standard of care for quite some time. Septations are also thought to be associated with increased length of stay and other outcomes like treatment failure and need for surgery. However, there was no grade analysis that was provided for that line of evidence. In terms of CT scan, theoretically, there's some utility here, right? There could be identification of an underlying abnormality like a mass, esophageal perforation, bronchopulmonary fistula, and so on. Sometimes it's also helpful when troubleshooting a pleural catheter, if it's malpositioned or not. It can identify mimickers like a lung abscess. And just to review, once again, synchronous lung cancer is picked up in up to 10% of cases of empyema. The 2023 guidelines state that there are certain features that are more in common with pleural infection than other competing diagnoses like a malignancy. One is this aforementioned lentiform configuration of pleural fluid. The other would be this split pleural sign where you do see visceral pleural thickening along the lung. You see hypertrophy as well as increased density of the extrapleural fat, as well as a presence of a pulmonary consolidation. Individually, though, however, the sensitivity of these features is quite poor. The guidelines also highlight the results of a retrospective review that developed and validated a potential CT-based scoring system. So there were different items here. One was pleural contrast enhancement. The others were pleural microbubbles, increased extrapleural fat attenuation in a large fluid volume, with pleural contrast enhancement receiving 3 points and the rest 1 point each. And if the CT score was 4 or more, the study did find that it could predict mortality and or need for surgery. It is very difficult to clinically differentiate the presence of a complicated effusion requiring a chest tube compared to a simple effusion that may just get better with antimicrobials and time alone. As such, the 2010 guidelines recommended pleural fluid sampling on all patients with a pleural fluid depth of at least 1 centimeter, especially if there's an associated pneumonic illness, recent chest trauma or surgery as well. They also advised that pleural fluid pH be performed on all samples because it is the single most powerful indicator to predict a need for chest tube. The 2023 guidelines build on this, so they recommend the use of pleural fluid and other parameters to categorize the risk and in turn the likelihood that the underlying collection would need a pleural drain. So the 7.2 cutoff for a high risk or drain requiring effusion, not any different. What's new is the proposal of an intermediate and low risk group. So basically, if you have an intermediate pH between 7.2 and 7.4, you look at the pleural fluid LDH, and if that's more than 900, especially in the setting of ongoing fever, low glucose, suggestive CT scan, that patient should probably get an indwelling catheter, an intercostal drain rather, or a pigtail catheter. For low-risk patients, these would be patients with a pH of more than 7.4, greater than or equal to 7.4, and those patients likely do not need a pigtail catheter. They also issue some general good practice points. So certainly when you're evaluating these patients, we're not just going to be focusing on the microbiology. We do want to be comprehensive and think about other etiologies as well. So cytology should be sent on all patients, at least 25 cc's, if not 50 would be better. For microbiology, they recommend that at least 5, if not 10 milliliters of pleural fluid be inoculated into both anaerobic and aerobic blood culture bottles. They also want us to know that there can be falsely elevated or decreased pH measurements because of the presence of air or lidocaine, although there really shouldn't be lidocaine, as we should be using a fresh syringe, specifically an ABG syringe, to send these off. And they also want us to be mindful of alternative diagnoses that can also have a low pH and loculations, such as rheumatoid effusions. The new guidelines state that there's currently no role for serum biomarkers to diagnose pleural infection. It's also important to know that the individual composition and biochemistry between areas and locules of a very loculated effusion can differ. So if the results don't really fit with what you're seeing clinically, the patient's not responding, you really should repeat the procedure, target a different locule, and see whether the composition's a bit different. So long-term survival is good if prompt treatment is initiated. So a 2019 systematic review of over 200,000 patients with pleural infection found that the median length of stay was about 19 days, and that the median short-term mortality, either in hospital or 30-day, was about 4%. There was a cohort study of over 9,000 hospitalized individuals led by the ISIS Queens group, and they found that the 90-day readmission rates related to pleural infection specifically was around 5%. And this didn't really significantly differ if the patient was treated medically or surgically. There also have been various cohort studies demonstrating a one-year mortality of around 20 to 30%. Sorry about that. So long-term morbidity is really quite infrequent. So a pleural peel is seen in the more organized spectrum of pleural infection, and with timely treatment, it can potentially resolve, but this is over months, right? So you can ultimately get residual pleural thickening without functional impairment in about 15 to 20% of patients. Within that group, rarely you can get progressive pleural fibrosis or fibrothorax, which represents very extensive, incapacitating fibrosis that does lead to lung function impairments and does lead to significant chest symptoms as well. How frequent a fibrothorax develops is not really clear. The hemothorax data suggests it's around 1% or less, and I would imagine empyema would be on a similar order. Other rare complications include pleural calcification, empyema necessitans, which is a movement and migration of pus through the skin and soft tissue, ultimately fistulizing with the skin, and then lymphoma, which really has been described on a case report level in Japanese populations, thought to be related to EBV infections. So the 2010 guidelines stated that at the time, there were no reliable clinical, radiologic, or pleural characteristics that can accurately prognosticate patients at the initial presentation. However, the updated 2023 guidelines have put forth a conditional recommendation on the use of the RAPID score as a risk stratifying measure, which can in turn be used to identify patients who are high risk, where more aggressive interventions can be targeted or front-loaded. So the RAPID score is a 5-unit or 5-item score, where the R is kidney function, A is for age, P is for the purulence of the fluid, I is the infection source, and D is for diet or albumin levels. There are low, medium, and high risk categories based on score cutoffs of 2 and 5. It is the most robustly studied prognostic score and the only one that has been prospectively validated. From a number of baseline clinical characteristics, the authors found that these 5 in particular predicted poor outcomes, including 3-month mortality and need for surgery. It was validated both retrospectively and prospectively, and in the prospective data, with the prospective cohort study, they found that it did predict 3-month mortality quite well, with a hazard ratio of around 3 and 11 for those with medium and high risk scores. The 2023 BTS guidelines did not make any specific good practice points or recommendations with regards to microbiology or antimicrobial therapies, although in the body of the text, they do recommend possible regimen. So we're just going to review what we know from 2010. Basically, anaerobes should be covered essentially in all patients. Macrolides are generally not indicated. Penicillins plus minus beta-lactamase inhibitors, metronidazole, cephalosporins, all thought to penetrate the pleural space well, but aminoglycosides do not, so they should be avoided. As well, empiric treatment for hospital-acquired empyema should cover MRSA as well as anaerobes. Initially, patients should be on IV route of antimicrobials, and this can be changed to oral once there's improving markers of sepsis. There is no role for direct or intrapleural antimicrobial therapy. Now, duration, still kind of up in the air. There has not to date been an adequately powered study answering this question. The 2010 guidelines suggest a minimum of 3 weeks based on your usual clinical, biochemical, radiologic responses and follow-up. So that's something that's still not clear yet. So considering the significant role inflammation plays in the generation of pleural fluid, corticosteroids have been entertained as a possible adjunct treatment. There was a large cohort study looking at patients with underlying community-acquired pneumonia, and they found that those who were prescribed regular inhaled corticosteroids pre-admission were less likely to develop a confirmed by thoracentesis parapneumonic effusion, and when the effusion did occur, it was generally smaller. However, there were a lot of missing details. They didn't talk about the underlying dose of steroids, how long they were on them, what type of ICS, so whether it was budesonide or something else. So the lot more questions than answers really coming from that. There was an RCT of children with a mean age of 5 looking at the role of high-dose intravenous DEX in parapneumonic effusions. And overall, they found that this did shorten the time to clinical stability and symptomatic improvement. But this relationship was especially the case in those with simple rather than complex parapneumonic effusions. In adults, the STOP trial was the first study looking at the systemic anti-inflammatory therapies or corticosteroids in general in adults with parapneumonic effusions. However, overall, it was a negative study. So yes, it was a small study of about 80 patients with pneumonia and parapneumonic effusion, diagnosed and confirmed in the usual way for most patients. However, not all patients had their pleural fluid sampled. When it was sampled, the mean pH was around 7.27. They were randomized to placebo versus DEX 4 milligrams BID for 2 days. And they had various outcomes. Overall, no significant difference between the corticosteroid and the placebo arms in terms of normalization of vital signs, inflammatory markers, radiologic response, length of stay, and need/duration for antimicrobials. The prior 2010 BTS guidelines do recommend chest tube drainage in those meeting the following criteria. So frank pus, turbid or cloudy fluid, if organisms are identified on microbio, if pleural fluid pH is less than 7.2 in the setting of a suspected pleural infection in pneumonia, or if there are loculations. Those who do not meet this criteria can theoretically be treated with antibiotics alone, so long as there is adequate progress on this treatment. In terms of the size of the tube, at the time in 2010, there was no consensus on the size of the optimal chest tube, but they felt that a small bore, typically defined as 14 French or smaller, was recommended as adequate for most cases. In the recent guidelines, though, there were 2 key drain recommendations. One was to insert the drain if patients had high or medium risk pH cutoffs, as mentioned before. So basically 7.2 or lower, or between 7.2 and 7.4 with high LDH. And that 2, a small bore catheter should be used as the initial drainage strategy over early surgery. And why is this the case? This is really based on this one fairly large retrospective study, which is the only direct comparator study of chest tube size in pleural infection. So patients were treated with a wide range of chest drain sizes ranging from well under 10 French to well over 20, which would be a large bore. They had 400 patients with pleural infection. The vast majority of patients did have visibly purulent fluid, and they did see that incidentally, patients with larger chest tubes were more likely to have pus. The mean pH certainly convincing of a complicated effusion with around mean of 6.6 to 6.9 across all the different sizes of tubes. And then they analyzed patients based on the size of their tubes. So less than 10, between 10 to 14, between 15 and 20, and more than 20 French in diameter. Overall, they found that there was no significant difference in terms of the need for surgery, mortality, which was the primary outcome, the combined primary outcome, nor length of stay, change in X-ray findings, or lung function at 3 months. However, not surprisingly, the larger bore chest tubes were associated with higher pain scores. So overall, the results suggest that smaller size tubes would be an appropriate initial treatment choice for pleural infection. Before moving on further, I just want to talk about some general practice and good practice points in terms of chest tube management. So after these patients get their pigtailed from IR and they float up back to the ward, the tubes invariably are going to be connected to a simple straight drain. This is really meant to be temporary, and the drain should be soon connected to an underwater seal system. And this serves multiple purposes. One, it allows for much more accurate output recording. Two, the underwater seal acts as a one-way valve, facilitating air to leave the pleural space, but more importantly, reducing and eliminating really air entering the patient with inspiration. And three, it allows the potential for suction to be added if needed. While smaller bore chest tubes are recommended based on the available data, there is theoretically an increased risk of blockage from the fibrin and the pus that comes out. There is no robust study comparing, maintenance flushing versus no flushing or different kinds of flushing regimens. However, the intrapleural enzyme studies and the chest tube studies in general, by default, did have regular flushing. And this typically was quite onerous, at least from a nursing perspective. It could be every 6 hours or TID, using at least 2 or 3 saline flushes at a time. Suction was also adopted by default, but not, the decision to use suction isn't really guided by any strong data. So there is no adequate trial evidence to make a recommendation. So moving on to intrapleural fibrinolytics. So this was first used in the late 1940s, and following this, there were a number of small, randomized trials and observational series demonstrating and confirming improved outputs and improved radiologic appearance. But on a large scale, not until the past 10, 20 years or so, were outcomes in terms of like disposition, mortality, evaluated in great amount of detail. So in 2010, the BTS guidelines stated that there was no indication for the routine use of intrapleural fibrinolytics, and this was largely based on the negative MIST-1 RCT, which is summarized here. So this was an RCT which looked at the role of intrapleural streptokinase for 3 days in those with confirmed pleural infection. And they found that there was no significant improvement in, mortality, rate of surgery, or length of stay. There were more adverse events that were seen in patients that received intrapleural therapy, namely more chest pain, more fever, more allergic reactions. Now, in 2011, so the year after the guidelines were published, the MIST-2 RCT was published also in the New England Journal. This was a blinded RCT in which patients with pleural infection were randomized to one of 4 study arms. So double placebo, TPA alone, DNAs alone, or combination TPA or DNAs for 3 days, twice daily at the doses mentioned here. The vast majority of patients had small bore tubes, and treatments were commenced the day of chest tube insertion. So that deviates a little bit from current recommendations in clinical practice. The primary outcome was radiologic improvement, and the secondary outcomes were various. And table 2, lifted from that study, just summarizes the primary and some of the main secondary outcomes. And we see that only combination therapy with both TPA and DNAs led to a significant improvement in all outcomes, including a 75% reduction in referrals to surgery and halving of the length of stay. There was no significant difference in the adverse events between treatment arms, but there was a non-significant increase in serious events in patients receiving combo therapies, including intrapleural hemorrhage, hemoptysis, and GI bleed. So with that in mind, how safe are intrapleural fibrinolytics? So the bleeding rates across various studies of TPA without DNAs does vary considerably, anywhere from like 2 to 12%. So this study was the largest to date, looking at bleeding risk in combination therapy specifically, and it was published in 2022. It was a multi-center retrospective study across, over 20 centers in the US and the UK, and they ultimately had data of on over 1,800 patients. So here overall, they found that there was a pleural bleeding risk in about 4.1% of patients, and it was fairly clinically significant, right? You can see here in terms of what happened afterwards, more than half of patients needed a blood transfusion and about a quarter needed, ICU or admission or intensification of care, plus minus surgical exploration. The pleural bleeding risk did not appreciably decrease in those where TPA dose was halved, but there was an increase if patients were concomitantly on therapeutic anticoagulation, but if their therapeutic anticoagulation was withheld for at least 48 hours, this did decrease the risk a little bit. Only the rapid score and the use of therapeutic anticoagulation were independent predictors of increased bleeding risk. And the other major adverse event that was picked up was pain requiring increase of analgesia. So based on European case series, reporting saline irrigation as a promising adjunct to surgery for pleural infection, this pilot RCT was conceived and conducted. So yes, it was small. They recruited 35 patients with pleural infection, diagnosed the usual way, along with a residual collection on CT despite chest tube. CT was performed a minimum of 12 hours after the drain insertion, and all of the tubes here were small bore, so less than 12 French. They're randomized to the treatment arm of TID normal saline, 250 cc's at a time, hung by gravity, versus typical best practice management. There was overall a significant improvement in the primary outcome, which is the radiologic appearance. And there was, in terms of secondary outcomes, a reduction in surgical referral, but no significant change in other important outcomes like length of stay, markers of inflammation, adverse events, and so on. Overall, yes, there are some limitations to the study. The clinical teams were not blinded, only the interpreting radiologists were. But it does suggest that intrapleural saline irrigation, which on the surface is easily accessible, probably a fairly cheap intervention, could improve radiologic resolution and reduce the need for surgical referral. Table 20 in the updated BTS guidelines has summarized the results of other intrapleural enzyme and other intrapleural therapies and their outcomes. In addition to the studies that we did touch upon, there have been a number of lower quality, smaller studies looking at urokinase, TPA and DNAs on their own, reduced dosage in terms of still BID, but like 5 milligrams of TPA, and so on. But in short, to summarize the findings, streptokinase actually was found to increase post-treatment complications and had no meaningful improvement based on the MIST-1 trial, so it's not recommended. Urokinase may reduce the need for surgery and reduce the length of stay compared to placebo. However, they did not have a specific guideline recommendation for that treatment. Saline irrigation can be considered if combination TPA and DNAs or surgery is not suitable or accessible. And where you think that intrapleural enzyme therapy is appropriate, it really should be combination TPA with DNAs. So in terms of surgery, prior observational studies have indicated that those with loculations and or purulent fluid are more likely to have surgeries. But ultimately, especially in the intrapleural enzyme, more modern era of infection management, many of these patients can eventually settle with medical management alone. However, that being said, even in the modern era, studies show that up to 20% of patients will ultimately require surgery to more definitively treat their pleural space infection. So who should be referred and when? So the 2010 guidelines to review state that if patients have persisting sepsis in association with a persistent collection, despite chest tube drainage and despite appropriate antibiotics, that surgery should be performed. In terms of an appropriate monitoring period, they suggest around 5 to 7 days. Although regardless of the presence of sepsis, if you do have a failure of chest tube drainage and antibiotics, this is worth at least a phone call to thoracic surgery to review the case and see whether there's a need for surgery. So the 2023 guidelines flesh this out a bit more. So I've pasted here table 19, which is an evidence review summary, looking at the impact on various outcomes between initial surgery and then initial chest tube or medical management. So the evidence does suggest that surgery, whether it's thoracoscopic or VATS or open thoracotomy, does reduce the need for repeat intervention and does have a shorter length of stay compared to medical drainage. However, I should note that in the comparator arms, none of the medical strategies included combination TPA and DNAs. So based on that, they go on to say that due to a lack of supporting evidence, there's still no role for early surgery for initial treatment. In terms of the type of procedure, the guideline advises that VATS is probably the one to go with over a thoracotomy. It's been shown to have lower OR times, less morbidity, less pain, less fistula and air leak formation, earlier return to work, just all around generally better for the patient. So whether early laparoscopic surgery or medical therapy with combination enzyme therapy upfront is superior has not been addressed. But I just want to highlight that there are 3 RCTs at various stages of recruitment and completion underway, and hopefully there will be some better evidence guidance for us in the next few years. In terms of follow-up, in short, the BTS recommends that X-ray and inflammatory markers like CRP be completed within 4 weeks of discharge, with more definitive imaging thereafter if you do see a persistent elevation in markers. They also recommend continued outpatient care, potentially up to several months. So practically speaking, and based on some European task force advice, a practical approach really would be to have that initial follow-up around 2 to 4 weeks post-tube removal and discharge, have a CRP done, maybe white blood cell count and an X-ray, and then you would do another follow-up at 8 to 12 weeks to ensure complete radiologic resolution. So in conclusion, wrapping up, so we know that complicated parapneumonic effusions and empyema are complications in about 10% of cases of community-acquired pneumonia. As we can see from our discussion today, there is a distinct lack of large, multi-center RCTs to guide the evaluation and management and refine that when it comes to pleural space infections. The mainstay of treatment has remained the same: early identification, appropriate empiric antimicrobials, prompt evaluation, and drainage of associated effusions. Imaging certainly is a helpful adjunct. Just to review, there is a possible CT score that we can use. We know that ultrasound has some very convincing findings, and we now know that the rapid score can help prognosticate patients and maybe inform discussions with patients. However, pleural fluid analyses, especially pH testing, remains of critical importance. The initial treatment of complex effusions and empyema now should be based on medical drainage as opposed to surgical, although once again, there are CTs designed to potentially challenge this. When medical drainage is sought, small bore catheters should be used, and after a short period of monitoring, combination intrapleural enzymes is the way to go. So TPA plus DNAs. And in short, thoracic surgery, low threshold to involve them, definitely involve them if there's persistent sepsis in association with a persistent collection despite an adequate course of medical therapy. And I believe that's it. Thank you. Thank you for your time.
Thank you so much, Dr. Chari, for this overview and update on the management of Parapneumonic effusions. Is something that we see, as you alluded to earlier, common in our internal medicine practice. And there's absolutely a few tips that will change our practice here today. Just for the audience, as usual, if you have a question, please write it in the Q&A section and we'll read it out. And if you would like to ask your question in person, please raise your hand and I'll bring you in. Starting, we have a question from Dr. Graham Johns, and so it's actually really good. Is talc officially dead?
So I think it's there's a distinct lack of mentioning of talc or other pleurodesis within the guidelines. So I would say the short answer is yes, at least for management of this specific condition.
Is there any, I know we're talking here about parapneumonic effusion, but I know that there are other types of effusions that, like malignant effusion, that where talc has been used. Is, in your knowledge, is that an area that we still use it, or?
Oh yeah, for sure. So I would say things have shifted in the past, several years or so. I think the mainstay of therapy, or for MPEs or malignant pleural effusions, it really depends on the patient's anticipated prognosis. But nowadays, there's a shift to indwelling pleural catheters, which may or may not itself lead to autopleurodesis just from the tube being in there and causing local irritation. But in patients where you know that there's no trapped lung, there's no significant pleural peel, and you know that you can get decent opposition of the visceral and parietal pleura, talc is on the table, whether it's done surgically or at the bedside. And it is something that the NP physicians and thoracic surgeons will discuss with patients who do present to NP. So that absolutely, talc is on the table for that.
Thank you so much. Question from Dr. Cox. Has widespread availability of portable ultrasound impacted the detection of Parapneumonic effusion? Example, early detection versus finding them on more often on an X-ray or avoiding their complications. So, is there? I had a similar thinking. It's like, is the increased frequencies due to earlier detection, more availability of tools to find them, or looking for them more, or is it truly an increase? So, thoughts about that?
For sure. I think in terms of the incidence increase, I think it's theoretical because of access to imaging, like especially bedside ultrasound and CT. If you look at the 2010 guidelines, it's very much focused on plain film and X-ray, and it does talk about the potential use of ultrasound. But at the time of writing, it's not widely accessible. But things have changed dramatically. That being said, to Dr. Cox's question, I don't think there's any specific data looking at how ultrasound has impacted in terms of early detection, but I think it's a theoretical consideration from what I was able to gather. Yeah.
So with early detection and sort of like preventing the complications, you've alluded to the recommendation of draining effusion if it's more than 1 centimeter in size. So with that, just the fact if you drain, if I'm in practice and I have a possible pneumonia and I see the effusion, I drain, it doesn't look infected to me, I don't drain it, all the pH is not too high, then would that reduce the risk of complication or early treatment with antibiotics because of pneumonia? Or is this, are patients who develop effusion, and infected effusion will develop infected effusion anyway? Thoughts around that?
Yeah, for sure. So I think the key thing is not to have diagnostic closure. I mean, certainly if you do have an effusion in the setting of pneumonia, I think by default, assume the worst, assume that it's biochemically complex. And if it is safe to do a bedside aspiration, even if it's not therapeutic, it should be sampled. And I think you can be reassured if biochemically it does appear normal. And furthermore, if the patient is improving clinically. However, I would have a very low threshold to reimage, resample if the patient is not responding appropriately.
Very good. This question here about this technical, I'm not very clear about, so I'm going to just read it. How come thoracics use 2 milligrams by 2 syringes in 50 ml normal saline, and respirology use TPA in 30 ml with DNase alpha? Expect any consensus here in the near future?
So I think the short answer is no. I think there's been a lot of variation in terms of how TPA and DNase has been administered. Some of it driven, admittedly, by physician convenience, right? When you look at the initial MIS2 protocol, it's actually sequential administration of TPA and DNase. So basically, you would administer one, you do a clamp for an hour, you come back, administer the next, clamp for an hour, set it to drainage, and then do that again later in the afternoon. And you imagine if you have a couple of patients like this on your ward, that's going to take up a lot of time. So that was the MIS2 protocol, which is backed by the most evidence. Subsequently, there were lower quality studies looking at whether you can give them at the same time, give them in smaller volumes, reduce the dose. And generally, the findings are supportive. So with that in mind, and also with some discussion with our local thoracics group, they do combine TPA and DNase. That does make things a bit more convenient, and it's not thought to be inferior. As to whether there's specific solution volumes like 15 or 30 cc's, I don't think that there's going to be any consensus on that, and I really don't think that would be highlighting the upcoming literature. I really feel like they're going to be sticking to the MIS2 protocol in the upcoming RCTs, comparing, let's say, surgery and that, because of how robustly it's been demonstrated.
That's great. So in follow-up, this question from Dr. Cox says about, sometimes giving one of the enzymes has a big benefit on fluid drainage. is giving DNAs only even justified?
So in short, for DNAs alone, I would say no. I think there is a role for TPA on its own. I would just have to review. I think I might have had a slide on this. Yeah, like in general, DNAs alone, either inclusive or there's a lack of significant improvement radiologically, clinically, need for surgery, length of stay, etc. But I think TPA on its own, it does reduce the likelihood of referral for surgery. So I think if you are going to pick one, whether it's because of what's available, maybe theoretically reducing risk of bleeding and whatnot, TPA would be the way to go, not DNAs on its own.
So that's a question from my end. I theoretically thought that DNAs would be less risk of bleeding than TPA. Is that correct, or is that just my wrong information?
So from what we've seen, at least in the data that's specifically looked at adverse events, I have not seen an increased risk of bleeding for DNAs alone. DNAs really is really thought to improve the viscosity of the fluid and in turn help the drainage. So it kind of boosts the effect of TPA. TPA will help with the septations and the fibrous tissue, but if you still have fairly jelly-like thick fluid, it may not drain as well. So that's where DNAs is theoretically has been adopted.
Oh, fantastic. Question from Dr. Irene Turpey. Can you explain the significance of pH? It's like I understand that's like why the cutoff is important for the draining and why. Yeah, what's the pathophysiology?
For sure. So in general, it has to do with a lot of just underlying metabolism of the bacteria that can lead to more acidic fluid. In terms of why the cutoff of 7.2 is chosen, I think largely it's something that's been adopted in practice based on like historical data from Dr. Light of Light's criteria and then other physicians of that era. So this number was kind of picked. It wasn't necessarily prospectively validated. Actually, the pH cutoff is, even though there's a lot of robust data to support it, it wasn't really picked in like a dose finding manner or anything like that. It's just kind of got grandfathered into future studies.
That's great. We have a question in person, Dr. Dorsani. Panji, go ahead.
Thanks, Madhu. That was excellent. I think you gave a very nice overview of where we are now with empahemas. I'd just like to mention that in as much that the studies comparing wide bore versus smaller bore tubes were in favor of smaller bore tubes, in practice, that's not always the case. And in fact, the studies have not looked at countries where there's a higher prevalence of use of larger bore tubes. And in fact, where I trained, we only had larger bore tubes. And in fact, the length of stay of our patients were much shorter than we're seeing now. Having said that, I think in most cases, we have patients, our patients are now being treated with smaller bore tubes or the pigtail catheter. But when they don't drain, I think it's always important to lift the dressings up and see what's going on in the pigtail catheter. And you'll be amazed at what's going on there when they're not draining. And I've seen pigtail catheters that are virtually like a corkscrew under the dressing. So always important, especially for residents and other staff, to lift that dressing up and see what's going on and why they're not draining. So that's the first thing. And I think, there are patients that I think would do much better than with a smaller bore pigtail catheter. The second point I'd like to mention, I think, even though I haven't looked at the details of the MIST-2 study, but in fact, it seems that the benefits of intrapleural thrombolytics are much better with the combination and usually given at the same time. And I think that also saves a lot of time and decreases the length of stay.
Mm-hmm. I mean, I agree in principle with your first point. I think the theoretical advantage or I guess equivalent nature in terms of small bore versus large bore tubes really is contingent on proper management of the pigtail, right? This is not a set it and forget it and check the patient once a day kind of thing. If it's not being flushed, if it's not connected to an auto water seal, and the system is not working and the drain is not improving, I'm not sure if that's a failure of the drain so much as a failure of us as the physicians managing that tube. So it really needs to be inspected really on a daily basis.
Thank you, Panji, and thank you, Dr. Chari, for answering that. I have a question about, in sending for investigations when you drain the fluid, and I've, like many of us, experienced like really the yield of cultures is not great, right? So, and I heard you talking about, inoculating 5 to 10 cc's in blood culture, both anaerobic and aerobic tubes, or bottles, I should say. Is it a practice that you would advise us to start doing? I do a few of those every time I'm on CTU, doing it at the bedside, like we used to do with the acidic fluid cultures at the bedside, inoculating in a blood culture bottle. I've never done that for pleural fluid. I'm hearing about it, which is, what are your thoughts? Would that increase the yield and maybe target better antibiotic? Understand that it's still polymicrobial in a way, so.
Sure. So yeah, I mean, the yield of standard cultures is about 50 to 60%. It's not great. And one thing that's worth noting is that blood cultures may often be the only source of positive microbiome in these patients, in about 10 to 15% of patients. So I think it's also good practice in a blood culture as well. So in terms of the blood culture bottles, so yeah, I would say that is a standard practice. It is something that I do when I do thoracentesis. And the guidelines state that you should be sending it in multiple different media. So yes, a plain white top or orange top container, plus inoculation in both anaerobic and aerobic culture bottles. However, things happen. If it's just a diagnostic tap, you have a small amount of fluid, they do recommend that you prioritize inoculating the culture bottles before the plain top containers with the same volume, at least 5 in each.
Okay, that's very helpful. My last question is about managing getting the accurate pH readings. In my previous lives, been told pH does change with the environment, and you need to put it on ice and stuff like that. Is that true, or do I just send the usual pleural fluid in any container and let the lab deal with it? And usually the nurses will send it like.
Fair enough. So in terms of pH, really, it should be sent with a fresh ABG syringe with all of the air extruded from it, because that can affect the pH result as well. Like it can falsely elevate or make it seem more basic. Absolutely, delays in sending it can artificially increase the pH and in turn, falsely reassure ourselves that we're not dealing with something that's more complicated. I think some of the older guidance also talked about extruding heparin that might be in the ABG syringes, but now I think they're all powder coated, so it's not really a thing that you can do. To my knowledge, I don't think that the heparin that's coated within the ABG syringe would affect the pH, although I haven't admittedly looked into that in a great amount of detail. But yeah, it should be sent in the ABG syringe, no air, as quickly as possible.
Fantastic. Madhu, this has been really a great round, very practical, evidence-informed, reviewing the recent guidelines. There are a few things that I'm going to incorporate in my practice. I'm sure many of my colleagues will as well. Great discussion and handling the questions. Dr. Saty also sent you a comment thanking you for the grand rounds. It's really excellent, very clinically oriented and scientific. So thank you so much. We're at time. Hope everyone has a good rest of their day. And next week, we have grand rounds hosted by St. Joseph Hospital at the same time. We'll see you then. Thank you.
Thanks for having me. Take care.